Good evening. Thank you for joining us for Endocrine Hypertension. My name is Phoebe James. I'm a Professional Development Officer with the Hunter New England and Central Coast Primary Health Network. Before we go any further, I'd like to acknowledge the traditional custodians of the lands that we're all meeting on today and pay my respects to elders past, present, and any First Nations people joining us. Just some housekeeping for those of you online, please send through your questions. If we do have time, we will get to them, but you'll find that question box on the right-hand side of your screen here. Please just pop up your hand and we will run to you with a microphone. Please wait for the microphone so that the people at home can hear. Phones, if we can just make sure they're on silent, that would be great. And just for bathrooms, if you go out that door and around, follow it around, you will find the bathrooms. I just wanted to thank our wonderful sponsors without which we could not have things like this, Abbott and Lilly. So thank you to them. And it is my great pleasure to introduce the amazing Dr. William Yu, endocrinologist with the Diabetes Alliance Plus program.
Thank you, Phoebe. So a disclaimer, I'm not Emma, and Emma was slated to run this talk. I don't look like Emma, but I'll do my best. And it's a fairly interesting topic for us, so I might just do a little bit of an introduction to Diabetes Alliance Plus for people who may not be familiar with it, but it's a program run across the Hunter New England district to improve and upskill practice with regards to diabetes, specifically initially designed for general practice. But as our remit has grown in the last 12 months, we're now expanding to as many allied health or para-health scenarios that we can get involved in. And one of the big things that we've done in the last 12 months has been the introduction of an advice line that you may or may not have heard about. So it's a office hours manned advice line by an advanced trainee with access to a consultant, and it's designed for diabetes questions and endocrine questions. And one of the things that we found during that process was discovering that a lot of the questions coming from general practice and outside general practice was endocrine related. And we looked at the topics that were being asked quite a bit, and that is the series of talks that we've designed for this year. We do have an audience in the room, so I just wanted to check, did anyone attend Dr. Judy Liu's talk around hypertension earlier on in the year? No, okay, excellent. So it's not the same, but there is a little bit of overlap. So the talk tonight's about endocrine hypertension, and as you all know, hypertension is a problem that increases the risk of cardiovascular mortality and stroke risk in the general population. And for the most part, hypertension is what we consider essential hypertension, where there's no obvious reason for why the person's developed hypertension. But in this talk, we're going to talk specifically around endocrine hypertension. So that's hypertension where there is a secondary cause. So there's a reason for why the person's got hypertension. And it's important because if there is an identifiable secondary cause and it's something that can be treated, and frequently it is, then it's something you can undo the adverse metabolic profile of a person suffering from hypertension if that condition can be managed. So I would like to acknowledge the traditional owners of the country throughout Australia and recognize the continuing connection to lands, waters, and communities. We pay our respects to Aboriginal and Torres Strait Islander cultures and to elders past, present, and emerging. So hypertension is really common. I might just look this way. 1 second. So it's really common. Up to 1 in 3 Australian adults have elevated blood pressure. And the most interesting thing is that a lot of them are not aware of it. And so if half of the people with elevated blood pressure are aware, then only 1 in 6 adult Australians have a diagnosis or a label. that they're aware of, and only a third of those on treatment are at the target. And so that takes you up to 1 in 18 persons who are at the target of a blood pressure less than 140 on 90. And as you all know, there's a little bit of variation around discussion around what the targets are going to be. And for the most part, we prefer having a target under 130 on 80 millimeters of systolic. But again, that needs to be titrated to the patient that you've got in front of you without exposing them to added risks. So hypertension is really common, and it's it's a leading cause of preventable deaths. And it does that by adversely affecting the metabolic profile of the patient that suffers from it. And that it means increasing the risk of stroke, heart disease, kidney disease, heart failure, and other things that you might not think about, like atrial fibrillation and even dementia. So if you look at this graph, it's a modeling of, in the States, of a cause-specific model for the number of deaths you can prevent if you treat the condition. And hypertension, by far and away, outstrips the rest of the conditions in this graph, including hyperlipidemia, colonoscopies, so screening programs, colonoscopies, mammograms, and aspirin prophylaxis. So it's probably one of the highest bang for your buck treatments in general practice. But often it's one in which, with the Diabetes Alliance model, we found that it's often a little bit of treatment delay or inertia, in fact. And very similarly, in the hyperlipidemia treatment space, we find there's a lot of treatment inertia. And I think that's true for all spectrums of clinical provision of care for hypertension. And often in acute hospitalization, it's often overlooked and ignored. But secondary hypertension is a subclass. So, if you talk about the broad space of hypertension, then we're looking specifically at the hypertension cases that have treatable causes. And that really builds up about 10% of people with hypertension. And the prevalence is higher in those with resistant hypertension. So what do we mean by that? So most patients follow a certain trajectory over their life course, where with particularly with hypertension, they get initiated on one blood pressure medication, another one gets added on, and another one gets added on over the sequence of time. But occasionally you'll meet patients where you've started treatment, things aren't going well, you've added on treatment relatively quickly, and they've gotten to 3 medications within a fairly short period of time. And by definition, anyone who's at 3 or more medications will have this classification of resistant hypertension. And the reasons for having secondary hypertension are quite varied, but endocrine probably takes the cake in terms of frequency. So if you look at the list there, that's endocrine being a vast majority of secondary hypertension, and renal being another one. Other things include vascular, drug, and toxin. So the reason we're interested in hypertension is because we think we can do some good. So primary aldosteronism is the most common cause of secondary hypertension and is actually a focus of the talk this evening. But when should you consider someone with secondary hypertension? So particularly someone who's had it from a young age. So, if they're 35, if they're 40, it's very unusual for someone to have hypertension or hypertension that is difficult to treat. So if someone turned up with who's age 60 and has new hypertension and is difficult to treat, is not as surprising as someone who's much younger. If they've got, as we talked about, resistant hypertension or severe hypertension, or if there's a clinical syndrome that is often associated with hypertension, if you can find a renal bruit, or if there's clinical features of endocrinopathies, which we'll cover in a little bit, then think about a secondary cause intuitively. If there's impairment in renal function, if there's hypokalemia, and on imaging, if someone's discovered an adrenal adenoma, then think about secondary hypertension. So we're actually going to run this through a few case studies, which I think nicely illustrate some of the common causes of secondary hypertension. So case study 1 is a gentleman, new patient to your practice. He's 65 years old and male. And hypertension was diagnosed 10 years ago when he was 55. And so at diagnosis, he was treated with irbesartan and a thiazide combination. Hypokalemia developed, and he was commenced on potassium supplementation. He develops a persistent cough, the ARB hydrochlorothiazide ceased, and atenolol started. Hypertension remains poorly controlled. And on review with you, he's on hydralazine, atenolol, amlodipine, prazosin with a blood pressure of 150/90. And other past medical history includes treated obstructive sleep apnea and overweight. And one of the interesting things noted on his biochemistry is a potassium of 3.1 with reference range 3.5 to 4.5. So, does anyone want to venture some thoughts on what they would want to do next? Remembering this is a hypertension talk with secondary hypertension. No? Good. Okay. That's all right. So one of the unusual things about this scenario is a low potassium. So it is not uncommon to see it, transient hypokalemia, but someone with an established history of hypertension, hypokalemia, that's unusual. And it does raise the question of primary aldosteronism. So we'll talk about that. But it is interesting because this person's had long-standing hypertension. They're on 4 agents, which is another marker for resistant hypertension. They've got hypokalemia. And it's appropriate to screen for a secondary cause in this person. Now, bear in mind this person is 65, so they're a little bit older, but their blood pressure is still not controlled on 4 agents. It's a long-standing history, and so perhaps this process has been going on for a long time, and maybe there's a secondary cause that wasn't diagnosed. So screening should include an ARR, so that's aldosterone-renin ratio, and we'll talk about that again in a little bit. So one of the things we did was to adjust the medication. So if you remember, hydralazine, atenolol, amlodipine, and prazosin. We've now taken him off atenolol, and we've put him on Span-K and verapamil. So these are antihypertensives that won't interfere with our testing. And often one of the biggest questions is, how long do we wait? And we'll talk about that in a second. But on replacement, potassium then improves to 3.8. So we know we can address the potassium, but it doesn't fix the underlying problem. So this gentleman underwent an aldosterone-renin ratio, and as you can see, the aldosterone is 1700, the renin is 2, and the aldosterone-renin ratio is elevated. So we typically think about aldosterone-renin ratio as elevated if it's above 70, and certainly 6-fold higher than it should be. So I'm just going to take you back to school for a little bit, and we're going to talk about the RAS system. But this person, the screening test suggests that we've got an issue with aldosterone and issues particularly with primary aldosteronism. So if you look at this diagram in the middle, I'm just going to point out, so these are the adrenal glands, and they produce aldosterone. And aldosterone works on the kidneys. But prior to all of that happening, the aldosterone production is under control of angiotensin II, which is produced at the lungs, coming from a precursor called angiotensin I, which is then again created from a precursor called angiotensinogen, and that comes from the liver. So liver, lung, adrenal. But there is a mediator, and that mediator is this hormone called renin, and it's produced by the kidneys. And what renin does is it accelerates this process. And so if you think about the aldosterone-renin ratio, we've got someone with high aldosterone and low renin. And that means this is being produced, but that is being turned off. And so because it's an endocrine talk, there are lots of feedback systems. But if you've got a kidney that's not making renin, it's trying to turn off this process, but that's not successful. And so what you've now demonstrating is that you likely have someone who, anywhere from down here onwards, is making too much of one thing that is not in control. And in particular, in most cases, that is aldosterone being overproduced by the adrenal glands. So what happens when aldosterone reaches the kidneys? It then encourages the retention of sodium, and water follows sodium, and so you get sodium and water retention, and that increases your intra-arterial pressure. And if you remember back to school, you get an increased delivery to a apparatus at the end of the distal tubule called the macula densa, and in contact with the JGA, and this setup will then produce renin. You will get some inhibition of this process with atrial natriuretic peptide and dopamine, but one of the major things that happens with hyperaldosteronism is that as you keep sodium to keep water, you then lose potassium, and so you'll see that the patient's potassium often falls in hyperaldosteronism. So the role of aldosterone, put simply, is to maintain blood pressure through salt and water reabsorption, and one of the side effects that happens is that it excretes potassium. So that's the RAS system, and so in this patient with the high ARR, we're thinking about this process of aldosterone being inappropriately secreted out of control of this original system by the adrenal glands typically. And so the ARR is a ratio, remembering that in distant past we might have a few different units, so this is the current setup that we've got, and the ARR normal is considered under 70. So primary aldosteronism was classified by a surgeon, and the classic teaching is one of hypertension, hypokalemia, and adrenal nodules. But it's worth remembering, but it's not the whole picture. So you can have one or more of these and still have the problem, and you don't have to have all three. So if you now think about the superset of what we've got hypertension, and then we've got this group of hypertensions that are considered secondary hypertension, so they have a definable cause. And then we now have, in that subset, we've got primary aldosteronism. Then inside primary aldosteronism itself, so adrenal gland that's making aldosterone out of control, we've got some separation still. And that includes this thing called Conn syndrome. And so that is when you've got a lesion that's identifiable there's an identifiable lesion that is unilateral. And so you've got a one-sided aldosterone-producing adrenal adenoma, and it composes about 30% of this subset of hypertension. And most commonly, though, we actually have someone who will have bilateral idiopathic hyperplasia of their cells in both adrenal glands, and they're rarer causes that we probably won't touch on today. But as I mentioned before, Conn syndrome actually diagnosed by a surgeon. I think he took out like a 6-centimeter adrenal lump when he first made this categorization, and he admitted the patient for like 30 days or 300 days, something wild that wouldn't happen these days. So this is a subset of a subset, but it's relatively important because if you've got primary aldosteronism above and beyond just essential hypertension, you have increased risk of stroke with an odds ratio of 2.5, atrial fibrillation odds ratio of 3.5, heart failure odds ratio of 2, I don't know, I think that's CKD, and then kidney disease with odds ratio of 2.09. And the data suggests that if we have an identifiable surgical disease and you treat it, you can actually improve that risk back to baseline, depending on whether you can get them off medication or not, but you can certainly make a significant improvement in their metabolic outcomes. So, as mentioned before, there's an increased risk of adverse event even compared to those with essential hypertension and when controlled for blood pressure. So, really important thing about primary aldosteronism, and you might be wondering, why are you talking about primary aldosteronism if it's a subset of a subset of a subset? And really, it's very interesting because Jun Yang down in Melbourne is doing some preliminary data, or I think they've published, and one of the biggest findings is that maybe even up to 30-40% of people might have some degree of primary aldosteronism that isn't diagnosed. And so it's going to be an expanding field, and it's probably going to eat up a lot of what we consider to be essential hypertension. So how do you diagnose primary aldosteronism? I think first you need to consider it. So most of our patients will either come to us with already a diagnosis of hypertension. We're making a new diagnosis of hypertension at the time. And the patients that you really need to think about whether this is a real possibility is those who have hypokalemia or those who have resistant hypertension. So again, as mentioned, more than 3 antihypertensive medications. There are some other things to consider. So adrenal adenoma in and of itself doesn't mean that you're going to make primary aldosteronism, but if someone's seen something on a CT scan somewhere, it's definitely worth thinking about, as hypertension is so common. Sleep apnea also has an association with primary aldosteronism, and Emma was telling me that in a very recent study, about 30% of people with OSA in that limited study had PA, and I was quite surprised by that, it's a very, very high number. Or if there's a family history of early onset hypertension or stroke under 40, if there's a history of atrial fibrillation in the patient, or if there's a first degree relative with primary aldosteronism. So one of the messages coming out from the work done in Melbourne is that anyone really being diagnosed with new hypertension, think about doing the screening up front. Because, as you all know, once you've started them on treatment, testing becomes quite complicated. So the first test is the screening test, so that's the aldosterone-renin ratio. Again, you've got to think about a patient with that increased risk. This is the main issue. So if someone's on medication, the test is quite unreliable, and often it's the medications we're using to treat their hypertension. So if you look at the duration of recommendation for cessation, it ranges from 2 to 6 weeks. So what we will typically do is if someone's on these medications, we will stop their medication, wait that duration of time, and then repeat the test. There are a few other things to consider, but we'll come to that in a second. So as you can see, the ACEs, ARBs, the beta blockers, very common medications. In fact, non-steroidals and SSRIs, we say to wait 2 weeks, so take them off the medication for 2 weeks. Diuretics, SGLT2 inhibitor, the recommendation is 4 to 6 weeks. And for myself, I tend to err on the side of 6 weeks, and most of my patients will be on the combination medication with a thiazide diuretic. One of the issues, though, is that your patient might then have uncontrolled hypertension, and you need to provide them a safe alternative. And so there are some medications that, even though they do affect the ARR, it's not very bad. And so these are the medications we would consider using. So verapamil, hydralazine, prazosin, moxonidine, and very frequently we actually have patients on all four. The other thing to consider is that being on the combined oral contraceptive pill, and during the luteal phase of the cycle, you can have a false positive of an ARR. I won't walk through this, but if you looked at, if you prescribe verapamil, if you prescribe these medications, there are a range of doses that you can use. But one of the major things is that people don't typically like prazosin. It can give them postural hypotension, and they can often get dizzy and palpitations and dry mouth. So do warn them before you start them on these medications, because it can be quite, the side effects can be quite problematic. So it's a bit of a minefield to do all of that. And often, intermittently, there are some patients where you actually cannot safely manage their blood pressure. So you take them off the medications and the blood pressure gets up to 180, and it really is not really, doesn't feel very safe to wait 6 weeks to do the testing. And so if it's not possible, then sometimes we will do the test on medication and give some degree of interpretation. But one of the things to highlight is that if someone's already on spironolactone, because spironolactone is a direct antagonist, if you remove it, you can actually precipitate a hypertensive crisis or precipitate hypokalemia. So just be very careful if someone's been on long-term spironolactone and has good blood pressure on it or not. When you've got someone who with an ARR less than 70, they're unlikely to have primary PA. If they're unwilling or unable to proceed with testing, or particularly if you think they might not be a surgical candidate, then you could just trial medical therapy. And this is reasonably acceptable as long as they're aware that they're declining further investigation. So there's a whole host of things we can do in terms of further investigation. But this gentleman, we're coming back to our case and we'll talk about what happens. So he's confirmed to have primary aldosteronism with the endocrinologist. A CT scan shows a right adrenal adenoma, and localization studies confirm a right adrenal secreting excess aldosterone. And he was treated surgically with a right adrenal resection, and he's off all blood potassium tablets and has a normal blood pressure. So a fairly common scenario for us. And the key takeaways is that primary aldosterone is potentially curable. Consider PA in hypertension and hypokalemia, even if they've had blood pressure for a really long time. And consider in resistant hypertension, sleep apnea, atrial fibrillation, new onset hypertension, and a family history. and use the aldosterone-renin ratio as a screening test. If you can, change the medications, wait 2 to 6 weeks depending on medication, and then retest. And if not possible, just test. And depending on the number that you get, you can ask for advice. Or if you still think that there's a good pretest probability of this person having PA, just send the result and ask for advice. Or you can always consider empiric mineralocorticoid receptor antagonist therapy. So, any questions on case study 1? No? Good. It's a pretty common condition for us to see, and probably much more common than we understand. This is case study 2. So, this is a 58-year-old male, 2-year history of hypertension, so a little bit younger than the previous gentleman. 2-year history of hypertension, becoming harder to control, now on prazosin 3 milligrams TDS, verapamil 240 milligrams daily, and perindopril 8 milligrams. Potassium is normal, and there's no adrenal nodule on the CT scan. So, does anyone have any thoughts? Good. Because it's a secondary hypertension talk, this person's probably got secondary hypertension. All right, good. I think the flag here. So the real big thing here for me is that things are becoming more difficult. So there's been either there's a progression of disease, but it's fairly young into the course of the disease. So I definitely will be thinking about secondary screening in this person. And the lesson in this one is that there's no real reliable phenotype. So hypokalemia is not a universal feature. In fact, most of the people I see with PA don't have hypokalemia. And adrenal adenomas are very common. So you'll see lots of CT scan that says, hey, there's a lump, and most of the time there's nothing happening. But we'll talk about that again a bit later. You can have very mild hypertension, and you can have very severe hypertension, or you can have no hypertension and really bad hypokalemia, and which we've seen as well. So the percentage of people with overt primary aldosteronism is probably around 15% of all people with hypertension. If you think about the number of people walking in your office with hypertension, that's quite a few people. And in terms of resistant hypertension, the overt PA then becomes a significant proportion. And this is the work that's being done in Melbourne. It's like, what is this degree of continuum? So this is a relatively recent publication, 2022. So 14% of patients with newly diagnosed hypertension in general practice in the Australian population eventually were diagnosed with primary aldosteronism. And so the severe phenotype is probably just the more extreme example that we're noticing, and there's a whole host of people who may benefit from treatment even with a less severe phenotype. So we screened case study number 2 for primary aldosteronism. But before we did that, what did we do? We took him off perindopril. And so we then altered by putting him on a different medication. So we chose hydralazine in this case, and we repeated the ARR. And so the aldosterone is 415, the renin is 2.1, and now we have an ARR of 198, and so that's high, yes. So we then get to this big box of what do we do next? So we're going to talk about this. And it's not, you don't really have to remember all of the details, but it gives you a sense of what happens when you send a patient to us, because often it's a fairly lengthy process, and it can take a period of months before the patient actually gets to any resolution. And so it is often important to word up with them that this process does take a bit of time. So if we've got someone with BAND or case of PA, so hypokalemia, low renin, aldosterone of 550, we've got a fire, as in where there's smoke, there's fire, and we typically go straight to a CT scan, and then we do the true diagnostic step. But if we've got someone who's a sort of bit in the middle, who they don't have these classic symptoms, then we think, and their aldosterone isn't particularly elevated, then we think about this thing called a seated saline suppression test. And as you know, in endocrine, we love our dynamic tests. And so if you want to show that something is being made too much of, you just try and suppress it. And so to do that, you just give lots of saline. And so what we're trying to really show is that we can't actually turn off the aldosterone production with a seated saline suppression test. What does it involve? The patient goes to a facility, they sit there for about 4 hours, they get their blood measured, and in intervals, and then we are measuring the aldosterone before and after. So it's a fairly straightforward test for the patient to undergo, but they have to be seated upright in a chair for 4 hours, can't go to the bathroom. If that's positive, then they'll have a CT scan, and if depending on what then gets decided, they might end up having this thing called adrenal vein sampling. If they then have unilateral disease, and if they consider the surgical candidate, which probably should be considered beforehand, then they will have surgery. And if it's bilateral disease, which is, as we saw, up to 60% of this population, then you'll end up on medication. So adrenal vein sampling, so this is just a simple diagram looking at the anatomy of the adrenals, but essentially in adrenal vein sampling, we have our radiologist colleagues advance a catheter up to both adrenal veins and then sample there and to demonstrate that one side is producing aldosterone more than the other. Often in these tests, the other side will have suppression, so because it's being exposed to high degrees of hypertension, it will turn itself off, and so you'll have one side that's typically much more productive in terms of aldosterone. As you can see, they're not quite the same, so they're not symmetrical. And one of the issues with adrenal vein sampling is that sometimes the radiologist will have difficulty getting access to the vein. And so intermittently, patients will have this procedure and not have a result because of the difficulty with access. But we will then typically reschedule another AVS. Well, and this is a really good question. Is this all necessary? Because it is an invasive procedure for a common condition, hypertension, that you see very commonly. It is important because if we don't do it, if you use only CT scan to direct whether you should have surgery, you end up with what we call best correct management only about half of the time. And when you could have helped someone with surgery, and it's not done because of the CT, that happens quite frequently as well. And there's about 6% where the wrong adrenal is resected. So they've done a scan, they've seen a lump on one side, the patient's got primary aldosteronism, but actually the active gland is on the other side without a lump. And so it's really quite useful. It is a lengthy process though, and it is an invasive procedure. So it's really important when we meet the patients to discuss with them that that's what's going to happen. This diagram sort of just walks you through that information, but essentially open circles are bad, open squares are bad, and the rate of error for AVS is much, much lower than the rate of error for CTs. So if you looked at all the combinations, all the empty spots are, erroneous CT judgments, whereas with AVS, the erroneous CT judgments are only in that small group. So this patient then had primary aldosterone confirmed on testing, and they underwent adrenal vein sampling, and right aldosterone excess secretion was confirmed. Again, remembering that this person had no lump on their scan. So he had a right adrenalectomy and had a biochemical cure with a normal ARR after surgery, but it doesn't necessarily mean clinical cure. So you might hear sometimes that we talk about biochemical and clinical cure, and that means that the patient comes off all medications altogether. But even without that, there is some data to support that if they've got biochemical cure, you're going to improve their metabolic outcome. I did want to put this slide up because we've talked about the medications that can interfere with the ARR. We've talked about MRAs, ACEs, ARBs, but one of the things and the OCP, but one of the things I should point out is that having someone with hyperkalemia or hypokalemia is actually going to interfere with the test. And so when we get them to that second level of testing, we're actually making sure that the potassium is right before they come into for testing. Otherwise, our test is actually considered not valid. So important to know. So primary aldosteronism is common. There's no definite phenotype, and not all have hypokalemia. Again, consider PA in people with hypertension with these features, and the correct diagnostic workup is important for correct management. Any questions on case study 2? No, fantastic, good, excellent. So case study 3, a little bit of a difference. So this is not PA, I'm going to say that up front. So this is a 47-year-old female, so put your thinking hats on. She's usually well, no regular medications. She comes to see you for new onset hypertension, but she's also noticed a few more symptoms. So she's got fatigue, she's got weight gain, and she's got oligomenorrhea for the last 6 months. And so when you see her, you're like, ooh, yeah, you've got a round face. She's got facial plethora, so redness in the face. And then she's got violaceous stria on examination. So her stretch marks are purple. They're not pale. These are keywords for endocrinologists. And you also note that she's got impaired fasting glucose. So does anyone want to hazard a guess as to what should we think about? Yeah, absolutely. So in the audience, we've got someone say Cushing's, and that's absolutely what we do need to think about. So round face, facial plethora, violaceous stria, very classic description. And the fatigue, weight gain, oligomenorrhea, although again, that's a very common complex of symptoms, but certainly definitely should think about screening for Cushing's syndrome. Now that's a difficult topic, so we'll probably walk through this slowly. So Cushing's syndrome is not a disease, it's a syndrome. And so it's not a diagnosis per se. It just means that you've got supraphysiological exposure to glucocorticoids, and that's manifested in the same way typically. And it has significant morbidity and mortality. And on one extreme, actually, you don't see a typical weight gain. So for people with extreme Cushing's syndrome, you might actually see weight loss, which is very counterintuitive. So exogenous steroid, again, is actually the most common cause of Cushing's syndrome. And endogenous Cushing's is rare. So we see probably 1 to 5 per million persons per year. So if you think about Australia, if we said 25 million people, that's only going to be, 100 persons in Australia a year. So it's really quite rare. And this is just the control pathway for cortisol. So again, we're talking about the adrenal glands. They make cortisol, and they're under control from ACTH, which is from the pituitary gland in the brain, which under control under CRH from the hypothalamus. And so CRH down to ACTH down to cortisol, and in Cushing syndrome, you have way too much of this. That can happen at any stage of this process. But before we get there, the things to look out for. Someone with hypertension, because this is hypertension talk, but the specific signs are that of facial plethora, the things we've already said, actually. Facial plethora, violaceous striae, easy bruising, and muscle weakness and atrophy. In fact, one of the most striking cases of Cushing's I saw was this person who couldn't get out of the chair, essentially, and that was actually one of the complaining symptoms. So they were sat in a chair, and in the clinical room, they couldn't stand up without the use of their arms. So there's a whole host of other symptoms that you might, signs and symptoms that you might see with classic textbooks, like the rounded face. We don't use moon face anymore. The buffalo hump, we don't use that anymore. So supraclavicular and dorsal cervical fat pads. But one of the other things that can actually happen is a neuropsychiatric manifestation. And so it's really tricky because patients might present with cognitive dysfunction or psychosis. And if you're not paying attention, you might miss a diagnosis, although it's rare. But again, important to think about. So, and it makes it trickier because if someone's depressed, they can actually have this condition called pseudo-Cushing's. And that's where you will have testing that looks abnormal, and they don't actually have Cushing's, they're depressed, which is quite difficult to tease out often. Alcohol exposure can also give you a pattern of pseudo-Cushing's. And then we have these tiers of diseases, which really gets into the weeds into where is the problem. And so Cushing's disease, which is initially described disease, is that of a lesion making too much ACTH. So if you remember, CRH, ACTH, cortisol. ACTH is that pituitary controller hormone. And so you're making way too much ACTH and creating increased cortisol. Ectopic ACTH secretion is often ACTH from an external source, and it's even rarer. And it's important to know because occasionally you'll come across patients where you're like, this is really accelerated hypertension, very unusual, accelerated diabetes, and you do need to think about Cushing's, and then you get a set of results that don't quite fit, or you've got a clinical scenario that doesn't quite fit. And one of the things that I mentioned with ectopic ACTH is that you don't always get weight gain. Sometimes you get weight loss. And the reason for that is multifold, but ectopic ACTH can come from things like bronchial carcinomas and or other malignancies. You can have primary adrenal disease, and these are the causes of endogenous Cushing syndrome. So this is probably a bit you really want to know about, which is how do I screen for it? And the short answer is that it's difficult. But the morning cortisol and ACTH levels aren't particularly helpful. So if you think about it, you actually don't need to do the tests. It can be helpful, but not really. So the 3 tests that are recommended are the 1 milligram overnight dexamethasone suppression test, a 24-hour urine-free cortisol, and a late-night salivary cortisol. And they all have different benefits and difficulties. So for the 1 milligram DST, which we call as our short form, you take 2 by 500 microgram tablets of dexamethasone, 11 p.m. the night before the blood test, and the blood test has to be done in the morning. So the patient has to take the tablet, they have to then go the next day and in the morning have the blood test. And so if the pathology is really jammed up and then they take the blood test at 10 o'clock, it becomes a little bit less reliable. And so often I tell my patients, let the pathology know that you're coming in and you need a morning test and that you're taking a medication the night before. Some labs will organize that dexamethasone for you, but I typically tend to give a script to my patient. But make sure you limit the amount of dexamethasone or they'll come back to you with Cushing syndrome because you've given them 30 tablets of dexamethasone. So you almost certainly will get a false positive with estrogen or pregnancy, so 6-week washout if they're on the oral contraceptive pill. It's a very sensitive test, so you might get a relatively high rate of false positives. And in fact, there's a lot of discussion around whether you need a higher threshold in obesity. The 24-hour urine-free cortisol is difficult to do, but it's actually quite useful because it's a free cortisol measure. And you collect all urine from the second pass, so remove the first bit, and then everything that from there on day 1 to the first pass the next morning. Really, the patient needs to be compliant and be able to tip everything into the bottle. It's a fairly specific test, and it would be diagnostic for Cushing's if the measured free cortisol is 2 to 3 times the upper limit of normal. Because it's free, it removes a lot of the consideration around binding globulins and proteins. Late night salivary cortisol is the third option. It's a bedtime mouth swab, so not, historically said midnight, but really at bedtime. You need to do it at least twice, if not 3 times, and it's fairly convenient, but it's not that reliable in people who do shift work, and it's a fairly sensitive test, so again, you're likely to get a fair few number of false positives. And because the tests aren't really that good independently, we tend to do at least 2, if not more. And so in case study 3, this lady who's developed this violaceous stria, new hypertension, new dysglycemia, we decide to test for Cushing's, and that's often a long journey if you decide to embark on Cushing's testing. She's not on oral contraceptive pill. Her alcohol intake is 2 to 3 times per week and not large quantities, and she doesn't do shift work. And so what do? We do a 1 milligram DST. So baseline cortisol is 430. So I think the message here is, if you're thinking about Cushing's, really this doesn't help you that much. So baseline numbers don't really help you. What you want to see is a response. And so she's had 1 milligram dexamethasone, and her cortisol is now 155. What's the interpretation here? Yeah, she's not suppressed. That's right. Someone in the audience said no suppression, so she's not suppressed. So if you're giving steroid, you expect your body to turn off your own steroid production. And that's generally the principles for most of our testing. And the reason we can measure it is because we don't measure dexamethasone, we measure cortisol. Otherwise, we'll just be measuring dexamethasone. But she's not turned it off. So the normal number is under 50, and she's at 155. And so she was appropriately referred to endocrine, so she may have Cushing syndrome. And so we then undertook more testing. So we had a 24-hour urine-free cortisol 1 month after the dexamethasone. So remembering that everything we do interferes with the next test. And her 24-hour urine-free cortisol is 423. and the late night salivary cortisol is elevated. So she's got 3 measures that are all elevated. And so she was then diagnosed with Cushing's syndrome. And one of the things that was done was an MRI of her pituitary. And in the MRI of her pituitary, they noted a lesion. And she then underwent a transsphenoidal resection of the pituitary adenoma, which was the cause for Cushing's syndrome. So occasionally you get pituitary lesions that aren't the cause of Cushing's syndrome. And she's now in remission and needs ongoing follow-up. So her blood pressure normalized off all treatment, her fatigue, plethora resolved, which is nice, and she's had weight loss of 5 kilograms and her stria are fading. So this is a good outcome. So one of the key points of this is that endogenous Cushing's is a rare but important cause of endocrine hypertension. It causes significant amounts of morbidity and mortality. And you do want to try and look or pick up on those specific clinical features. So the violaceous striae and the things we talked about before, so the muscle weakness, because your pretest probability then is improved. And beware the false positives. So depression, alcohol, they can falsely alter your test results. Screen with either the 1 milligram overnight dexamethasone suppression test, the 24-hour urinary-free cortisol, or 3 by late-night salivary cortisols. If they're on the OCP or HRT or in pregnancy, avoid the 1 milligram dex, and the baseline is helpful but not diagnostic. And if there's any concern, always just send through the referral because then we'll muddle our way through it, as it's often a lengthy process to work out what's going on. So that was case 3. Did anyone have any questions about Cushing's? Good. Okay. All right, case 4. It's getting more exciting. And the reason for that you'll see in a second. So this is a 57-year-old female. So entry case, or a parallel case, and she presents with heart failure, hyperglycemia, and hypertension, and 6 hours prior had a surgical procedure. I'm going to stop there and ask if anyone wants to venture a thought for secondary hypertension. She's had an insult, or had an event, and now has presented in florid heart failure. So this is a typical description, and not typical presentation, but a typical description of someone who's had a precipitated event. And in this case, we'll talk about it in the next slide. I have a missing blood pressure. That's not good. She presented with heart failure, hyperglycemia, hypertension. She was admitted under a specialist cardiology service, and she was diagnosed with reverse Takotsubo cardiomyopathy, and the blood pressure from memory was 210 on 80. Does that change anyone else's thinking? So hypertension, yes, but very, very severe hypertension. And so, there you go. It's much higher than that. So this description is one of precipitated hypertension. And so it's a hypertensive crisis. And one of the things to think about is adrenaline. And so that's why I said it's going to get more exciting, because there's adrenaline. But she presented with classic symptoms or classic precipitation of a pheochromocytoma, but that doesn't necessarily not always how they present. She underwent testing in intensive care, which is a minefield in and of itself, but her plasma metanephrines were elevated, more than 4 times the upper limit of normal. Plasma metanephrines were elevated more than 4 times the upper limit of normal, and the urinary metrics were also similarly elevated. So for those who are not aware, metanephrines and normetanephrines are considered adrenaline byproducts. She underwent CT imaging, and she had a right adrenal lesion that was 3 by 2 centimeters with indeterminate Hounsfield units, which is all fairly concerning. Now, this is not an image for her, but I might just point out what we're looking at. She was diagnosed with a pheochromocytoma given the degree of elevation of the metanephrines and normetanephrines, and she was initiated on alpha blockade first, then followed with beta blockade. And so it's really important in these patients where you're suspecting that a crisis has occurred and you're looking for a pheochromocytoma or adrenaline-producing tumor, that you don't put them on beta blockade, because you can make things worse until you've done alpha blockade. She underwent surgery following preparation and is currently cured and off antihypertensive. So just walking you through this is a coronal slice of a patient. That's the right kidney, that's the left kidney, and that's the adrenal lesion that this diagram indicates. So pheochromocytomas and paragangliomas are another extremely rare cause of hypertension, but occasionally you will meet them. They're derived from neuroendocrine tumors, from chromaffin cells from the neural crest, and they secrete adrenaline metabolites. When they're not in the adrenal gland, they're called paragangliomas, and these are where they could occur. And so we think about the adrenal glands most commonly in these people with these florid crises, but you also have to think about the nodes in which these neuroendocrine tumors might rest. And in fact, one of the most interesting cases that I came across was where the lesion was in the bladder, and so if it'd been taken as just a bladder tumor, then things might have ended up badly when they were put under anesthesia. So the symptoms are associated with adrenaline products, and these are the common symptoms. So sweating, tremor, nervousness, anxiety, weakness, paleness, sometimes visual problems. You get palpitations, hypertension, headache, nausea, vomiting, constipation, hyperglycemia, so new onset accelerated diabetes with new onset hypertension. Just have a think about whether this could be a problem. Weight loss is fairly common, and mass effect depending on where the problem is. And hypertension is not always present, although this is a hypertension talk. And sometimes the hypertension comes in paroxysm, so they come and go. One of the things that you get taught in school is that the patients with pheochromocytomas often flush, but that's not true. So they actually go pale, so they become clammy, and that's often a little bit more specific. They mostly typically don't present with that case that we started off with, but they mostly present as primary hypertension, just an accelerated course most of the time, but not all of the time. And it's really important to know if you've got someone who's got this diagnosis, is that you have to think about other problems. So up to 40% of any PPGL, is what our acronym is for this, is associated with other endocrine clusters. So you've probably heard of MEN1, MEN2, and von Hippel-Lindau syndrome, and they tend to come up with other endocrine problems. So anyone with this set of problems, we need to think about this. Diabetes occurs in up to 1 in 3 patients with a pheochromocytoma. They get a leukocytosis. They can get a secondary erythropoiesis, and counter to intuition, they can sometimes present with hypotension. They can get hypothermic. They can get confusion, and as mentioned, they don't usually have flushing. The things to know about is beta blockers make things worse. So beta blockers, if you've got someone you're suspicious of, try not to initiate that. Alpha blockade is probably the way to go. Some of the medications like these can also trigger off a crisis. So if you've got someone with that diagnosis, just be careful when you're prescribing medications. So the screening test, how do you diagnose it, or how do you look for it? These days we use a plasma test. You can still get a urinary test, and we often use that as confirmation. But it's a plasma-free catecholamines, and the main thing is that the patient actually needs to be flat. Which is hard for a pathology place to do. So they need to lie down for about 30 minutes, and they actually need to be lying down when it's collected, and they need to be collected on the ice. So often, if there's a test that's positive, it's often because the collection has been problematic. And so false positive results are very common. We have a dynamic test that we can use, but we almost very, very rarely use these days. A lot of medications cause the numbers to look abnormal. And so if you've got an abnormal number, refer them on, and then we can look at these things. But this is my favorite one, cocaine. As in, not for me, but I'm closing out that case, but does anyone have any questions for case 4 with the pheochromocytoma? So we do see them intermittently come through John Hunter, and the stories are often quite wild when they come through. But I did want to spend a bit of time talking about adrenal incidentalomas.
Sorry,
yeah, go ahead.
So was the surgery a stressor that caused that to come out? And was the Takotsubo's cardiomyopathy from also the pheochromocytoma?
Yes.
Okay.
So the surgery was considered a precipitant, and the reverse Takotsubo was considered the sequelae of a pheochromocytoma. Yeah. Great. So coming to adrenal incidentalomas, you probably would have seen lots of scan reports come to you and saying there's a lump, what do I do next? And it's very, very common. So That's not quite right, but the definition is any lump in the adrenal that's greater than 1 centimeter that's discovered by accident. And so actually this is quite technical. So if they've got any symptom at all, it isn't an incidentaloma. And when they do broad autopsies, around 2.5 to up to 8% of adult individuals will have a adrenal lump. And they really, really have to be asymptomatic. So you have to think about the subtler presentations of adrenal lesions. There are many, many differentials. I won't walk through the list, but they're divided into where they come from. So the cortex, the outside of the adrenal, or the medulla, the inside of the adrenal. You have other reasons for why you might have a lump in the adrenal gland, myelolipomas, teratomas. But really importantly, if it looks funny, you have to think about metastases. And if you're thinking about metastases, don't order a biopsy because you'll seed it somewhere. And other conditions like infiltrative diseases like amyloid, sarcoid lymphoma. Occasionally we do have to think about TB in the adrenal glands, so just be mindful. And occasionally you'll get Frederick-Waterhouse syndrome, which is hemorrhage into the adrenal glands. But adrenal incidentalomas are really common. What should you do? So if they've got an adenoma, I think the main thing is if it's not an adenoma, so if it's not a discrete lesion, then really be guided by what the next imaging modality is, and that will be based on the advice from the radiologist. Because if you've got something that is a metastases, then you probably want to quantify it better imaging-wise and do an MRI. But if you've got a lump on one side or two sides, you can do screening tests. So you do need to think about the endocrine component of what the adrenal gland does, and that is to test. So again, we're screening for aldosterone, but we're not doing aldosterone, we're doing the ARR. We're screening for cortisol, but we are not testing cortisol. We're doing a 1 milligram dexamethasone suppression test usually, but not always. And really think about whether your patients are truly asymptomatic. So very, very occasionally, you will have females with abnormal production of DHEAS, which is a testosterone product. And so they'll present with virilization, so more hair than normal, vocal change. Very, very rarely, you'll get estrogen overproduction in males. And so we don't usually do this, but think about aldosterone, cortisol, and also think about the catecholamines, which is the adrenaline products. If the Hounsfield unit on the scan is greater than 10. So typically under 10, they're almost never a pheochromocytoma. Again, don't biopsy these things. If there's any question, refer them on. And when should you be worried? So any lump over 4 centimeters needs to come out. Any lump that has greater than 20 Hounsfield units, really think about malignancy. And if they're over 10 Hounsfield units, then you need to do a full assessment, and that includes the catecholamine production. If it's been decided that they have nothing to worry about at the moment, but if you do a follow-up scan in 6 to 12 months and you see rapid interval growth, then you also need to be worried. So typically the pattern for this is if it's identified, it doesn't fulfill any concerning criteria, they then get a repeat imaging in 6 to 12 months, and if that looks stable, then you can push out the imaging and discuss with the patient what it means for them. But anything under 10 Hounsfield units, the new guidance typically says you may not need to image again. But always bearing in mind the patient in front of you and the clinical scenario that you've got. So that's adrenal incidentalomas. I did want to touch on acromegaly, but did anyone have any question about adrenal incidentalomas? No. How much time do I have, Phoebe? Okay, excellent. I did want to talk about acromegaly as another relatively rare cause of secondary hypertension. And it's a syndrome in which you have excess growth hormone. And so these patients will come to you telling you about how they've now need to change their shoes. They need to change their belt, their rings. They have to resize their rings 4 or 5 times in the last 12 months. And then people are saying they're looking toothy because their teeth are starting to widen out and space out. But we have a bunch of clinical features that we'll look for, and we're looking for active disease. So that's sweating and oily skin, but a lot of people will have that. But they'll progressively get worsening joint pain, worsening sleep apnea, headaches, voice change, menstrual change, carpal tunnel syndrome, erectile dysfunction. Sometimes you get hirsutism and hyperpigmentation, and then you'll end up with the cardiac complications of untreated excess growth hormone. It's very rare. It's worth thinking about. And if you test a growth hormone level, it's often difficult to interpret. So if you've got suspicion, just refer them on. And we often do suppression tests. So that's most of the talk. But I did want to point out this slide. So I think this slide is from a relatively recent paper, and it looks at what can we improve if we intervene earlier. And I think one of the big problems with these chronic conditions is that we often have treatment inertia, and that's true for diabetes, true for hyperlipidemia, true for hypertension. And this diagram shows that if you've got genetic susceptibility to early vascular aging, your progression through the disease spectrum is fairly rapid. So by middle age, you go from healthy to elevated blood pressure to a subclinical target organ damage, and then you're getting to loss of quality of life with cardiovascular disease. For most people, they're going to follow what we call an average life course. People blessed with excellent genetics will follow an ideal life course. But the point of this graph is that the earlier you can identify and intervene in a problem that may have a definitive treatment, or even if it did not have a definitive treatment, you then push that progression out significantly. And so you get an outsized benefit at intervening early on in life. So that's most of the talk. The key points to take away is think about the secondary causes of hypertension. And think particularly about the patient that you've got in front of you and the examination findings that you've got. Also the history, the family history. Often that's a little bit forgotten about when you're going through the hypertension history. Think about baseline testing and baseline screening. And then think about, particularly for PA, so primary aldosteronism, if they're not someone who will have surgery, then sometimes there's no point going through the motions of getting the diagnosis formally labeled. Just have a very frank discussion with them saying, this can be done, but surgery might not be an option for you, and then we'll use an MRA. But and it might need a bit of a nuanced discussion, and we're always happy to do that. So primary aldosterone is relatively common. Think about PA when you've got hypokalemia and adrenal nodule or not, or either. And they're more likely to have a surgically curable disease. But if you remember that diagram from before, it's not a definite cure. And consider an ARR on all new diagnoses of hypertension, remembering that up to 14% of new diagnoses will have some degree of PA. And when we're doing endocrine testing, we always think about the medications that interfere with our results. So, I think Emma's point was that really we need to get in this door. So once you have the suspicion that this hypertension isn't particularly normal or it's quite difficult to manage, then you need to think about whether you should be screening for an ARR if it's not been done already. And so if you get that result, then send an endocrine referral and we'll worry about the rest of the stuff. But it's often useful to word out with the patient if they've got an abnormal ARR, there's still a rate that it's going to be normal. And if it's not normal, it might take a while. That's it. Does anyone have any questions? Yes. Oh.
Thank you so much for coming out and talking to us. That was a really good talk. And I'm going to be paying attention more to people and looking at this possibility. I'm here because I had a patient last week whose cardiologist asked me to check her for primary aldosteronism. And she had preeclampsia when she was 20 with her first pregnancy. So one of my questions is, does that have anything to do with the aldosteronism? She has a lot of family members with hypertension. 3 of her 5 sisters all have high blood pressure. And she had very hard to control high blood pressure when she was in her 40s and was on 4 medicines, which she didn't tolerate well, took herself off. So now she's on an ACE and a diuretic, an HCTZ. So you've answered my questions there, although I looked it up in UpToDate when she was with me, and UpToDate says 6 weeks off medicines and verapamil and all the other ones, hydralazine. And I just wondered about that. And the other question I had, so that you answered almost all of my other questions. Oh yes, the other one was, in UpToDate it said sodium loading orally for 3 days and testing urine and blood, and you didn't mention that, so I thought I'll just bring that up. It's an UpToDate. I'll read it to you if you want me to. I was like, oh, is that something? And then the last thing is treatment inertia. You kept saying that, and we are GPs here, and we try so hard with these people with diabetes and blood pressure, and a lot of it's lifestyle related, and it's really hard. So just, we're not inertia. We're really trying hard, and we're telling our patients, please take the medicines and do the lifestyle changes. And as you know, that's really hard work, and just to let you know, we don't have inertia. We're doing it.
It's very fair. That's an interesting clinical scenario. So I think in that, given a strong family history, it's often useful to check with the patient if there's been a formal diagnosis. Because if there's an extensive family history, maybe someone's already been down that investigative route. If not, then she certainly should be screened for a PA. I agree with my personal practice is I wait 6 weeks of all medications, because I always, as you say, sometimes it's difficult to know exactly what's happening with the patient at home and what they're doing. And so I say 6 weeks. But it sounds like actually your patient might be quite tricky to manage without antihypertensives. And so starting the verapamil, starting the prazosin, that's often what we would do. But you will have a cohort of patients where actually the blood pressure is uncomfortably high, and then we would do testing on interfering medications. The interpretation becomes a bit more difficult, but if you've got results on interfering medications, just send through a referral and we'll look at the results. And then, on occasion, we will still proceed with the further testing, so even the saline suppression test, even the AVS on interfering medication, but that would be a very, very rare case, because the interpretability becomes really problematic. There are familial conditions in which the test will look abnormal or may not look abnormal, and there are genetically driven causes of hypertension. And so if there's a strong family history, definitely worth checking if it's been investigated, and if not, definitely send her through. Yeah.
What about the preeclampsia associated with?
I can't say I know off the top of my head about preeclampsia. Yeah. But I think from memory it is, but I couldn't tell you the numbers. Yep. The salt loading is important. So when we do our saline suppression tests and when we do our ARR, they actually recommend a salt-loaded diet when doing that. Yeah. Not sure about the urine thing.
It says UpToDate just
Yeah.
says 3 days, and it has the amount of sodium to take.
Yeah.
And it has a 24-hour urine test to do.
Okay. It might be an American thing.
It says oral sodium loading.
Yep.
Many centers and experts, including this author, use sodium loading for 3 days.
Yep.
After hypertension and hypokalemia are controlled, then it says testing protocol. The patient should be given guidance on the sodium content, and then afterwards they get 24-hour urine sodium excretion should exceed 200 milliequivalents to document adequate sodium loading. Urine aldosterone excretion of greater than 12 in the setting is consistent with hyperaldosteronism.
Oh, I don't think we do the urine test here. Yeah. Yeah. Good. Alrighty. No online questions. Fantastic. All right. Well, feel free to come up and have a chat if you're in the room, and always happy to take questions. Thank you.
Please join me in thanking Dr. William Yu again. Wonderful presentation. For those online, you would already have your evaluation pop up. If you want your RACGP points, please fill that out. For the people here, you have a QR code on your table, so you can tell us what a good job we've done. But thank you for spending your evening with us. We really do appreciate it. Look after yourselves. Thank you.